This talk might look simple, so I'll sticking to the basics. As you saw from the previous all presentations, the simple dictum is that in diabetic retinopathy, there is no easy clinical situation. We all know that laser photocoagulation is still the gold standard in the management of diabetic retinopathy and its complications, whether it's PDR or CSME. The same laser photocoagulation produces visual disabilities. There can be central visual loss caused by the development of macular edema or worsening of the pre-existing macular edema after PRP, peripheral visual loss from extensive scarring, and defects in contrast sensitivity and color vision after photocoagulation. In the ETDRS, which was performed prior to the advent of OCT, 18% of the eyes that underwent full PRP were noted to have macular edema on fundus photographs by 4 months. So, why does this occur? The pathophysiology of DME has been told by the previous speakers. To simplify it, it is because of the breakdown of the blood-retinal barrier. Other factors include, in a patient with PDR with extensive ischemia, peripheral ischemia, there will be upregulation of VEGF which causes DME, and retinal laser will cause inflammation due to tissue destruction and upregulation of IL-6 and cytokines which are inflammatory mediators and which can worsen the diabetic macular edema. Why does this edema worsen after PRP? As I said, there is oncotic fluid accumulation related to the tissue destruction which is caused by the laser PRP, and also laser-induced inflammation leading to inflammatory mediator release, and also due to increased permeability of the retinal capillaries. In type 1 diabetes, usually worsening of edema after PRP is not an issue, because unlike in type 2 diabetes mellitus, there are no other confounding factors like hypertension or any other thing. And in this type 1 diabetics, the DME is mostly directly related to the peripheral ischemia. So doing an aggressive PRP will relieve the ischemia, reduce the anti-VEGF levels, and thus can help in reducing the macular edema. This is a male patient, 35 years old, type 1 diabetic of 11 years, best corrected vision 612 in both eyes. You can see in the right eye, in the macula, there is a succinate retinopathy, both eyes PDR. But what is important is that periphery shows extensive capillary non-perfusion areas. There is absolutely no capillary perfusion from the arcade itself. And OCT showed diffuse macular edema on OCT. These are the patients which require aggressive PRP laser with focal laser to the leaking microaneurysms at the succinate area. In type 2 diabetes, if you are planning to do a PRP in a patient with very severe NPDR and DME, the first importance should be given to controlling of macular edema before you plan to do a scatter laser photocoagulation. But in the presence of neovascularization, both have to be tackled at the same time. You can't wait till the macular edema settles down and wait for the patient to bleed. So, like in this patient, it's a 54 years old patient, 636 vision, type 2, diagnosed as PDR with CSME, gross macular edema. The plan of management in this patient was we gave both eyes Avastin followed by PRP. But the most important thing is there should be a minimum gap of 1 to 2 weeks between each sitting of laser and a minimum gap of at least 2 weeks between your initial Avastin with focal laser followed by PRP. Preferably a micropulse laser, if available, would be better when compared to a conventional laser. As you can see from this OCT, after 2 weeks of gap of Avastin with focal, we started PRP, and every 10 days frequency, 3 sittings of laser. At 1 month post laser treatment, there was significant resolution in edema in the left eye, but right eye still shows edema. At this stage, when the neovascularization has reduced, you can go ahead and plan another couple of intravitreal injections again. Suppose if the CSME is gross at the time of presentation of a patient with PDR, consider loading dose of anti-VEGF or Ozurdex injection or IVTA injection if the patient is a pseudophakic or a non-glaucomatous patient. Like patient with a CSME and PDR, extensive NVE, NVD, a circinate retinopathy, we gave a Avastin with focal laser followed by PRP, significant resolution. The decision to give which injection along with your treatment of PRP is decided by the amount of thickening, the type of thickening, whether it is cystoid or spongiform, whether there are too many hard exudates, whether there is too much of neovascularization, cataract, glaucoma, or whether the patient has severe systemic diseases. The rules for treatment: without laser treatment, intravitreal drugs will have only a transient action. You just can't do a PRP and give intravitreal injections and wait for the macular edema to settle permanently. Always you should add a focal laser or a modified grid laser in diffuse diabetic macular edema. All the cases should need good metabolic control and serum lipid profile under control for the edema to come to normal or for the edema to not worsen. Again, another important point, it is not necessary that intravitreal injections are always compulsory. A focal or a grid laser with PRP will also do a good work. As seen in this case, patient with PDR with clinically significant macular edema and only post focal laser followed by PRP, there is significant resolution. So, to summarize it, the protocol for PDR with CSME, the treatment should be, if there is localized macular edema, consider focal laser with PRP. If there is diffuse macular edema with PDR, consider a combination therapy. If there are plenty of hard exudates, you can consider IVTA with focal laser followed by PRP. If there is significant macular edema without much of hard exudates but leaking microaneurysms, consider maybe multiple injections of anti-VEGF followed by focal laser with PRP. Glaucoma, IVTA is out of the question. If systemic diseases, Avastin is out. Consider alternatives like either Lucentis or Triamcinolone. Again, another thing important to note is that when the PDR is very aggressive, that is, when there is too much of fibrovascular proliferation, the spacing has to be definitely on a longer duration, because too much of laser or too much of anti-VEGF agents can increase the fibrosis and cause traction on the neovascular membranes and cause vitreous hemorrhage or TRD also. Simura and et al. Found that macular edema was more likely when the PRP was compressed at a 1 weekly interval when compared to 4 sittings at a biweekly interval. So in high-risk patients, spacing should be increased for PRP sessions. Whether can you predict in which patient the macular edema might worsen? There is a study by O and colleagues. They say that a thickened macula already at the time of presentation, the presence of cystoid macular edema and subretinal fluid serous detachment on OCT at baseline were significant predictors for worsening of the macular edema. Most important thing is, before we start the treatment for macular edema, always look whether the patient has diabetes under control, nephropathy, whether the patient is anemic, whether the patient is on glitazones, and also whether his lipid profile is under control. So, to summarize, in type 1 diabetes, the macular edema is usually because of upregulation of anti-VEGF, so the PRP should be aggressive. In type 2, give equal importance to systemic control. When the edema is very minimal, just increase the spacing between the focal laser and your weekly sittings of PRP. If the edema is gross, combine it with either anti-VEGF or steroids. When compared to conventional laser, if you have a micropulse laser, prefer micropulse laser. Always in a patient with macular edema and PDR, monitor with OCT frequently and intervene as and when necessary. Finally, laser still is the mainstay of treatment for diabetic retinopathy, that is PDR with CSME. Intravitreal steroids and anti-VEGF drugs have to be used judicially based on each case. Of course, intravitreal injections have significantly improved the outcome of management of PDR with CSME. Thank you.